Our next speaker is going to be Dr. Sal Pascual-Diaz. Unfortunately, he was not able to come in person as well, so we will also listen to his pre-recorded talk. Dr. Pascual-Diaz is a postdoc fellow at the University of Barcelona with Marina Lopez-Sola. He's interested in neuroimaging study of pain, and particularly in children. And today he's going to discuss multimodal approaches to study pain in adolescents. So without further ado, I will let you listen to
Hi, I'm Sal Pascual-Diaz, and I'll be talking about multimodal neuroimaging approaches to pain in adolescents. I want to start by saying that I don't have any conflict of interest. And with that said, I will start by giving a couple of definitions about chronic pain. In our case, chronic musculoskeletal pain in adolescents is defined as pain in muscles, bones, or connectivity tissues, lasting at least 3 months in adolescents aged from 10 to 19. It affects up to 46% of adolescents and is associated with persistent symptoms, reduced daily functioning, worse mental health, and increased risk of school dropout. Although we have different methods to treat that, chronic pain often persists into adulthood. So in this context, we want to study the brain mechanism behind that. And in our case, I'm working in the SPRINT project, which is a multidisciplinary investigation into the neurobiological and immunological mechanism underlying chronic musculoskeletal pain. We have different kinds of MRI data, and in this case, we will use diffusion data and functional data. For the structural data, we need to think about the connectivity matrices as direct connections between brain regions, and those regions are like first-order connections between two different regions in the brain, and we see those regions are connected, those regions are not connected, and we can weight that using, for example, number of streamlines or things like that if we use tractography. In the other hand, we have also the functional data. The functional data is the process that happens after n direct connections in the structural dimension, and we see how the brain functions after all that process. But right now, we don't have a proper method to move from one to another, because we can say that functional emerges from the structural connectivity. So we don't have, after n steps, we don't know how to predict one from the other. But we are trying to use this data to know how one of them can be related to the other one. And how can we do that? We can start using this example by this first matrix represents 4 regions and the structural connectivity within those 4 regions. But you need to think that in our case, we study this using 246 regions from the BrainEtome Atlas. So all of the examples that you will see here, this is like a little example using just 4 regions, but for the concept, but then we will use it in the BrainEtome Atlas. But here we have the structural connectivity for those 4 regions. But here we can only see if those regions are connected or not connected. So we know that, for example, region 1 is connected with region 2, and region 2 is connected with region 4. But we can use a proxy of connectivity by assuming that brain works as a network. I think that it's a fair assumption because it's something that we are used to do. And we can ask this structural matrix the cost of reaching points that are not directly connected by the structure. We can use for this the communication models. And it's like asking, what's the cost from moving to this unconnected region? And by do this, we can do it assuming that the brain connects to regions by using the shortest path length, the efficiency between them, completely random. But we can use different connectivity models, but at the end of the day, the question that we ask here is what's the cost to reach points that are not connected by structural information? And then we create a weighted matrix. This weighted matrix, it's more similar than the functional matrix here. So once we have this communication matrix and this functional matrix, what we can do here is to correlate region by region communication models and functional matrices. And what's the point of that? The point of that is to know how similar are the structure and the function. we are not trying to explain how one emerged from the other and how one works and how many steps are from one from the other one. No, we're just trying to say this one is more similar than this other one, to see if there are differences from them and see if these differences affect the mechanisms underlying chronic pain. But as I told you, well, we can make this and create for all subjects, or for n subjects, we can measure the coupling. This is called the coupling between the structure and function. But as I told you, we don't know if the brain connects to different regions by using shortest path length or by using random walks, or as we don't know, what we do is to create 34 different models, different communication models, to just characterize the different kinds of connectivity, and from all of them we will pick all the information, and we can create a model with all that information without knowing the specific path that the brain is using to connect to unconnected regions in the structural dimension. And in our case, we've done this using a sample of 198 subjects that their ages range from 12 to 18, so the mean age is like 50 and 64. For all of them, we have fMRI data. In our case, we will use a multisensory task. I will explain you the multisensory task later and why are we using the multisensory task. We also have diffusion data, and we also have clinical measures. For this presentation, I will use the PROMIS depression measure and quality of life measures. But why are we using multisensory data? We use multisensory data because we know that for people with chronic pain, they don't just have chronic pain, they also have multisensory hypersensitivity, and they feel unpleasant things that are common for all of us. They can feel unpleasant, the sound of the brightness of the TV, or the touch of the sheets in the bed, and things like that, the sound of traffic. And we found that the worse the unpleasant is for them, the more difficulties they have, for example, in physical, social, and academic activities. So we will use this task also to know how the function is related with the multisensory dimension. And the multisensory acquisition consists in 4 blocks of multisensory stimuli. That multisensory stimuli, it's a visual stimuli, a sound stimuli, and then they have to do a finger opposition task also to have a somatosensory stimuli too. And then it's with a resting state. So we have block of resting state, blocks with multisensory stimuli, and we compare those 2 blocks, and with that we can create a map of the multisensory activation. No, we can have the contrast maps for all of them and calculate the multisensory stimulation. As we can see here, we have activation in visual cortex, in somatomotor cortex, auditive cortex, so things that we expect to have. And also we can see here that they are doing the finger position task with the right hand, so we find more activation in the left hemisphere than in the right hemisphere. So with that, in our case, we have, for those 198 patients, we have the diffusion data. We have created the structural matrices by reconstructing the tractogram for all of them using constrained spherical deconvolution for the tractography, and then we created the matrices. And in the other hand, we created the functional connectomes. In our case, we decided to regress out the main signal of the task because we just want to see those different changes in metabolic rate that are modulating the multisensory stimuli. So we are using like a pseudo resting state measure, but affected by the multisensory, and in the other hand, the structural. And then we created the communication models, and then by combining them, we created a a set of measures for each of the models. What we see here in the first plot is the mean value for the coupling for the 3-4 different models that I explained that are based in different assumptions. For example, we can see just straight distance, we can see here characteristic path length, and different kinds of models of connectivity, of communication models. But then we have 3-4 different kinds of data, and we like to know how to explain coupling by using all of them. And to do that, what we did was to plot the different components of the PCA, and from all those components, we explained different clusters of variance. So we know that some of those models are explaining the same kinds of stories, and other models explains other stories. So by doing a hierarchical clustering to know the different numbers of clusters that we have here and the optimal number of clusters that we have to split our data set to have the higher amount of variance explained, we picked 5 different models based on that. So we clusterized this data, and then for each data we pick the maximum amount of variance in each cluster. And once we had those 5 models, we run again a PCA using these 5 models, and with this data we created a single model of coupling, and we call this an integrated communication coupling index. What we see here is how structure and function are related, and we see that for different regions, the structure and function are more related, and for other regions are less related. And the point of all of this is that once we know how similar are function and structure, we can then compare some of those regions with the clinical measures. And as I told you in the previous sections, the first thing that we did, was to correlate those measures with depression measures. And what we see here is that we need to think here that the higher the measure of depression is, the worse they are. I am saying that because, for example, in the quality of life, it's not this way. So right here, the worse they are, the higher the measure is. So here we have that for example, we can see the results. Here, those results are the results that are significantly correlated, coupling with depression after correcting using permutation correction for multiple comparison. And we see here that we have a very huge part of the insula that the more coupled this region is, the worse they are. We will go back into this because this is somehow tricky to interpret. So after presenting the results, we were talking about how to interpret those results. But at the end of the day, we have that for the insular regions, what we see is that for the higher the coupling, the worse they are. In the other hand, what we find here is something that it's like showing another dimension. We pick the depression as a measure of affective measure, but we also have other measures that represent physical measures. And one representative of this physical measure is the quality of life physical, that where kids respond things like they are missing school because of pain, or they are missing social events because of pain. So because physical pain. So we have a measure of how are they doing due to the physical pain that they feel. Here, as I told you, the better they are, the higher the measure. So we need to think this in reverse. So what we see here is the lower the coupling between structure and function is, the worse they are. And if you see here, the regions that are involved in this case are more the frontal regions. We have some regions mostly in the frontal cortices. This is also lateralized results in the right hemisphere, and also we have some basal ganglia results here. But how can we interpret this? For me, one way to interpret this and to visualize this is if we think about 2 dimensions, we have the structure and function, we can measure the coupling. It's the left picture, right? This could be the baseline measure. We have one measure of structure, one measure of function, and then we correlate one with the other, and we create a coupling measure. But there are some cases where we have functional reconfiguration, because this is some kind of changes that we do just in the functional level, because the plasticity takes longer, and we are seeing functional things that are happening in those patients. So to see a decreasing couple, what we see is an increase of functional reconfiguration. But then, if we see things this way, as we've seen in the results from premise depression, what we see here, we see that the worse they are, the higher the coupling is in the insular region. And what does it mean? What this means that the ones that are doing better are having more functional reconfiguration. So for them, in our particular case, what we see is that the ones that are doing worse are the ones that have less flexibility in those regions to readapt and functional reconfigure the function of these regions of the brain. But in the other hand, for the physical quality of life, we see something different. We see that the worse they are in the physical quality of life, so in the physical dimension, the lower the coupling in those regions, in those frontal regions. So what we see is that the ones that are worse are the ones that are doing more functional reconfiguration. So we are seeing here a maladaptive process. We are seeing that they are doing things there that are not good things. There are things that are making them feel worse. And with all of that, we can characterize the different regions and, in our case, see 2 different dimensions of things happening between 2 different mechanisms involved in chronic pain and in adolescents, and particularly in chronic musculoskeletal pain. Before finish, I want to thank my team in Barcelona. It's my team with lead by Marina Lopez Sola and in the Pain and Emotion Neuroscience Laboratory. I also want to thank the Spring team from Cincinnati, Stanford, and Toronto. And also I want to thank Wani from Korea, that all of us have been working together to put this project together, and we've been working a lot to have those results. And thank you for being here, for listening to me, and goodbye.